Good afternoon, everybody. Welcome to the presentation on comfort feeding only, managing feeding at end of life. My name is Simin Iqbal, and I'm the long-term care best practice coordinator for provincial projects at RNAO Home Office. Our guest speakers today are Dr. Evelyn Williams and Jennifer Wong from the Veterans Center at Sunnybrook Health Science Center. The session today will focus on comfort feeding only when oral intake is not sufficient to sustain life and if prolonging life with artificial hydration is not consistent with the resident's wishes, as expressed by the resident or their substitute decision maker. This session is being recorded so we can place it on our end-of-life toolkit for everyone to view, those who could not join us today. We are using the WebEx feature today, and just want to point out some of the features on here. If you need to get the event number for the technical support, click on the event info on the tab left corner. To expand to the full screen, click on view and then full screen at the bottom left corner, depending on your computer setting. Should you wish to provide feedback, click on the feedback icon. And we will be opening the lines for questions at the end of the presentation. But during the presentations, you can type in your question directly into the QA panel, and we will address these questions at the end of the presentation. So the three best practice guidelines that this presentation is going to be is based on is the end-of-life care, the oral health, and the person and family-centered care guideline. This webinar is intended for long-term care leaders who are facilitating practice change and direct care staff that will benefit from understanding comfort feeding only process and the goal of the feedings to achieve comfort by employing the least invasive and potentially most satisfying way to provide nutrition. As recommended and supported by the evidence, the following best practice guidelines will support staff and long-term care homes to provide person-centered approach to care at end of life. So our person and family-centered care best practice guideline has a recommendation, and one of them that is posted on the slide here. The presenters will focus on how the engagement of resident and family in decision-making and care planning that supports the recommendations, and as they are listed on this slide. For the end-of-life best practice guideline, by providing all the information, staff can support the resident and family to make a decision that supports their beliefs and their values. We are now going to invite Dr. Williams and Jennifer to take over the presentation and share how the team implemented strategies to support residents and families to utilize comfort feeding only at end of life. I'm just going to be switching over to the slides for Sunnybrook, so they will be taking over soon. Dr. Evelyn Williams has an MD, Masters of Health Administration, and is a fellow of the College of Family Physicians, and is the past president of Ontario Long-Term Care Clinicians. For long-term care physicians, she is the co-author and co-director for the Ontario Long-Term Care Medical Director Curriculum. She is also the medical coordinator for the City of Toronto Long-Term Care Homes and the physician lead for the long-term care peer assessment for the College of Physicians and Surgeons. Dr. Williams has a clinical practice working with an interprofessional healthcare team in the Veterans Wing of Sunnybrook Health Science Center, where she is the head of the Division of Long-Term Care. As an assistant professor in the Department of Family and Community Medicine, she teaches geriatrics and wound care to family medicine residents and leads quality improvement projects within the facility. Jennifer Wong is the clinical speech-language pathologist and holds a status-only lecturer appointment in the Department of Speech-Language Pathology at University of Toronto. Jennifer currently practices in long-term care and provides assessment, consultation for residents who require nursing home, chronic, and palliative care. Areas of interest include dysphagia, geriatrics, end-of-life care, and interprofessional quality improvement initiatives. In addition to clinical responsibilities, Jennifer acts as a clinical educator for master's level students in the Department of Speech-Language Pathology. Jennifer is the inaugural chair of the End-of-Life Palliative Care Interest Group with Ontario Association of Speech-Language Pathologists and Audiologists, and a member of End-of-Life Care Work Group within Speech, Language, and Audiology Canada. Evelyn and Jennifer, you can now take over, please, and you can advance the slides.
Thanks very much for that introduction, and thank you everyone for joining us. We are very, very grateful to be able to bring to you our approach for comfort feeding only, because we feel it has really helped us and helped families deal with difficult feeding issues at end of life. We have no disclosures, but we want to acknowledge the work of our interprofessional teams at the Advanced Dementia Units at Sunnybrook, Veterans of Care, particularly Kristen Paulseth as a speech and language pathologist, and Helen Young, who's a registered dietitian who worked with us in developing our resources. So our learning objectives for today are to discuss how we developed the comfort feeding only policy, including how we identified gaps in care and developed the program using quality improvement tools. We're going to discuss some of the background concepts, rationale, clinical indications for use, and components of the policy as it would be implemented in a long-term care home. And we're going to consider indications to identify residents who may benefit from a CFO approach. Finally, we're going to discuss some hands-on strategies for feeding residents at end of life. So we're going to start just with some context, how we got here. So back in 2010, we had a family come back from acute care, and they were very distressed. The resident had advanced dementia, so he had difficulty maintaining his fluid intake. And they had been in acute care. One day the resident was NPO, the next day they could feed them. And part of their caring for this resident was to be able to feed him. So they were really distressed. They wanted to know, well, what can we do to help? And this fluctuation between NPO and oral feeding had been very, very difficult. So we are a long-term care facility. We also have complex continuing care beds, total of 535 beds. It's for veterans, so our average age is 92.5, and then we have 56 dedicated palliative care beds. We're part of the larger Sunnybrook Academic Health Science Center, and we work with interprofessional teams. So here we are two of these buildings on a huge campus, and that means that we don't have to send our residents to the emergency room if they're dehydrated. We are expected to do IV or hypodermoclysis, IV meds, labs, etc. on site. So we don't have quite the dilemma in long-term care that you might have where when someone's dehydrated, they have to go out to the emergency room. But on the other hand, we have much heightened expectations from families that we would provide artificial hydration even at end of life. So there's our buildings. And so around the time that this family came back from Emerge, distressed, I came upon this article in the Journal of the American Geriatric Society that talked about comfort feeding only, a proposal to bring clarity to decision-making regarding difficulty with eating for persons with advanced dementia. And this just came at the right time. So comfort feeding only, that's careful hand feeding, offers a clear, goal-oriented alternative to tube feeding or artificial hydration, and it eliminates the apparent care, no care dilemma imposed by NPO orders. And this is reflected now for the Choosing Wisely campaigns. Both the American Geriatric Society and the AMDA, Society for Post-Acute and Long-Term Care Medicine, their very first one of Choosing Wisely is do not recommend percutaneous feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding. And they do talk about the risks of tube feeding being associated with agitation, increased use of physical and chemical restraints, and worsening pressure ulcers. So this has been very helpful in dealing with families who often come, and I know you've had this happen to you, they're going to starve to death, they're dying of thirst, what do we do? To step back and look at the risks and benefits of feeding, the fact that dementia is a terminal illness, and that these other attempts at hydration aren't without their risks, and so we can provide comfort without going there. So we developed a policy in 2011. We rolled it out with the involvement of our interprofessional team and staff education with our unit advanced practice nurses. And then we evaluated it in 2013, 2014, and we did a needs assessment. We analyzed the gaps between practice and intended practice with the fishbone. We did a PDSA cycle, 5 weeks of common myths and perceptions by email blasts. We did process mapping. We did unit resource folders to guide staff, and we wrote a family resource brochure. And on Choosing Wisely, there's also a little handout if you need something to give to families that also helps them understand why we don't automatically hydrate or put in feeding tubes. So, for example, now here's our little fishbone. What are the barriers to successful implementation of comfort feeding only? And we want to put this forward to you because this isn't really an easy top-down approach. It involved a lot of discussion and a lot of working out how things were and a lot of understanding to get there. So you've got knowledge gaps, staff values standing in the way, difficulty in process, whose responsibility is it, and then the family perspective, which we wanted to turn around. So here's our email blast initiative. Now, this is an alternative to the 1-hour in-service where you get everyone in the room and you talk to them and then they go away and forget it, or not. So every Monday for 5 weeks, there was a question sent out. This is an example. If someone's on comfort feeding only and they develop pneumonia, they should be made NPO, nothing by mouth. Is this true or false? And so staff would answer. 66% answered correctly, which means 34% thought we should put someone with pneumonia on NPO. But then after they did the answer, there would be an explanation of what the risks were and why the answer was false or true. So this is a different way of presenting education, and the lure was if you answered all 5 weeks correctly, you could get in a draw for a Starbucks coffee card, which we gave out. We had lots of uptake on this, but I'm putting it forward because it was an easier way than trying to get everyone in the room and talk to them for an hour. And so our aim statement was to address a needs and knowledge gap. We did email blasts. We assessed if we had addressed these gaps, and then we went to act on the remaining gaps. So that's standard QI stuff, but it was very helpful. So now I'm going to turn this over to Jen, and she's going to talk you through the rationale, indications, and components of the policy.
Thank you. So Dr. Williams has given us a nice overview of the path we've taken thus far and the journey that we've gone on in terms of this policy. And now I'm going to spend the next section or so speaking to what does it actually mean when we get there and what are our definitions. So this is an excerpt from our actual policy, and Suman did mention some of this before in her introduction. So I'm just going to reread some of this for you. That comfort feeding only refers to offering and assisting with feeding solely for the purpose of comfort and enjoyment when a resident is not able to eat or drink enough to maintain adequate nutrition and hydration, when oral intake is not sufficient to sustain life, and if prolonging life with artificial hydration is not consistent with the resident's wishes, an order for comfort feeding only is recommended. So I want to highlight those 2 points in green there, that really, A, the goal of feeding is now for comfort, for having a pleasurable eating experience. And we know that we've had discussions and we do not want to artificially nourish or artificially hydrate. And so you'll notice that our definition is rather specific. And again, just with a little bit of a QI lens, we would suggest, if you were to try to introduce or implement a policy like this, to be very explicit with all of your stakeholders in terms of what does comfort feeding only mean to you, because there are lots of different perceptions about what someone's vision could be for comfort feeding only, so to have everyone on the same page from the get-go is a really important consideration. So a little bit about why we chose the particular definition that we have. So again, we know that the resident is not able to meet their nutrition and hydration needs in the long term, and we don't expect this to get better. Usually this is related to a progressive illness, something that we don't think that there are going to be remediations for. And moreover, it can be in the context of dysphagia, but it might not be. So what I mean by that is there are many reasons why a resident could stop eating and drinking enough. Some of it could be changes in appetite, fatigue, level of alertness, difficulty swallowing certainly could be part, nausea, dry mouth, confusion or reduced awareness of food and fluid in the mouth, and so you do see this a lot in the advanced dementia population where there's just that change in terms of what does the sensory information of food in the mouth mean to someone. Positional difficulty, shortness of breath, this is just kind of a short list of some reasons why someone might not be able to eat or drink enough. Okay. So why choose a comfort feeding only approach? So Dr. Williams has already referenced this article, but effectively, again, just to reiterate the point, we know that people with advanced dementia do often have difficulty sustaining their oral nutrition and hydration. They often do lose weight, and we do consider comfort feeding only as an alternative to intervening artificially for those residents. One of the reasons is that we know that from a palliative care perspective, symptom management perspective, if we're looking at managing symptoms, so in this case hunger or thirst, that the symptom management piece really can be achieved with a fairly minimal amount of intake. And so what that means is that it may not take a huge amount of food, maybe not a full meal. From a dry mouth and thirst perspective, sometimes sips of water or even simply oral care have been shown to be quite effective at reducing some of those symptoms of thirst. And moreover, in some studies, there has been some evidence that if people push themselves to eat more, drink more to please family, sometimes they end up with some unintended consequences of discomfort or nausea because of that. So that's a little bit about why we might consider using some of the comfort feeding only piece, but another piece of evidence to consider, again, Dr. Williams has already alluded to this, is the fact that there are medical contraindications to both artificial nutrition and artificial hydration, and there are other healthcare costs associated with that. So some of the pieces we've already talked about are things like agitation, the need for physical or chemical restraints if someone is combative around tubing and things like that, any complications or pressure ulcers. And moreover, we also know that placement of a G-tube doesn't actually prevent someone from aspirating. So if dysphagia is the reason that this ends up being considered, it's an important consideration to know that the placement of a G-tube doesn't prevent them from aspirating on, say, their secretions or from reflux aid or anything like that. On the artificial hydration side, a big piece in our population is the fact that placement of, or use of, I should say, artificial hydration really can prolong suffering and can prolong the dying process. So again, in those cases where, you know, this is not going to get better and we are looking at people with progressive degenerative illnesses, the artificial hydration piece is kind of a stopgap in some ways and doesn't actually fix the underlying problems. Moreover, there are risks in terms of fluid overload, edema, CHF, and from an invasiveness perspective, it does require sometimes things like resiting of either hypodermoclysis or IV sets, sometimes lab tests for monitoring, things like that. So there's more frequent pricking, if you will, in terms of being able to maintain some of those things. As well as sometimes that can restrict someone from getting out and about to different places that they'd like to go if they are continuously hooked up to the tubing and to the pumps and things like that. So just to recap how we ended up with this definition of comfort feeding only and why we chose to go with this definition is from a clinical perspective, again, we know that there are risks associated with artificial nutrition and hydration, particularly in the context of end of life and end-stage disease. And we do know that really careful hand feeding can be sufficient in terms of managing the symptoms of hunger, symptoms of thirst. From an ethical perspective, again, there is a concern about when does prolonging life become prolonging dying? And the answer to that question is different for each family, but certainly it's a question to keep in the back of one's mind in the context of advanced and degenerative diseases. We also chose to look at this as our approach in an attempt to try to balance some of the needs to nourish and to try to actively care for someone with some of the staff concerns related to, oh, I don't want to be the one to give the last spoonful that someone aspirates on. And so really use of this approach in terms of feeding when we can in an informed way allows people to try to manage those symptoms of hunger, symptoms of thirst, but also gives people the space to be able to say, you know what, we shouldn't feed right now in this moment, and that's okay. And so, again, we kind of avoid the NPO, not NPO battle back and forth, but also try to manage the concerns related to starving and thirst and things like that. So those are our rationales and indications. So right now I'd like to switch gears a little bit and just speak to some of the things that you can actually do on the floor. So the first piece is identifying people who might benefit from comfort feeding only. And so it's just some critical questions to think about. A is, are they eating and drinking enough? Is this a pattern or is this a sudden change? Has this come on all of a sudden or is this an insidious change that's kind of been creeping along for a little while? What interventions have you already tried? Have you tried changing the foods, changing the liquids, addressing different preferences, and different things like that? So taking a good look at what has already been tried. So if you do identify that you think, you know, this person might be appropriate for a comfort feeding only type approach, then it becomes a question of how to have that conversation and changing the conversation. And again, I'd like to just reiterate that really what we try to advocate for here is to make it less of a withdrawing of care kind of conversation, so less of the we're not going to feed, these are the risks and so on, and to focus on the positive approach. What are we going to do? How are we going to feed? How are we going to assess when to feed? So to move more towards what we are actively going to do. If you want to look at some samples of conversations, there's a reference there by Karlowicz, Quill, and Meyer that has kind of an approach in terms of consensus building to come to decisions at end-of-life care. The Palasek, Tenno, and Castoret article also has some sample dialogues that you can always also take a look at. So sometimes when you might consider having this conversation, so during family conferences, particularly if they're around change of status, at the time of return from hospital, or if you see that someone has been deteriorating and you don't expect that it's going to get better. In terms of providing other supports, what we mean is also tapping into your interprofessional team. So what resources do you have access to? Might there be need for support, education from, say, social work, spiritual care providers? Do you have some of the different either recreation or creative arts therapies available or volunteer programs? So looking at what we can do in those times that we are not able to feed. Moreover, documentation is always crucial for all of us, so think about what processes you have in terms of documentation and forms and things like that. So for us, that means documentation in terms of our treatment plan or advanced directive forms, progress notes, family conference notes, and then care plans and cardexes and things like that depending on what your documentation conventions are. So some generic process pieces to consider. So what happens when the order is actually written, resident Mr. Jones is now on comfort feeding only, what do I actually do? So again, if you're looking to implement a policy like this, some things that do need to be hammered out are things like what are the processes for communication with the team, both verbally and in discussion, as well as from a documentation perspective. Is there an electronic diet order entry system, and how does that need to be engaged, and things like that? Again, what kinds of alternative supports can we put into place? What kind of education, what kinds of resources do we have for being able to support our families at this time? And I think, again, I've already alluded to documentation. So what we did as part of our QI process with this is we actually did formal process mapping, which Dr. Williams mentioned. And so we engaged stakeholders from, we had Dr. Williams involved, speech pathology, dietitians, food services, nursing, patient care managers. So we really got all of our stakeholders involved and did a formal process map, which ended up being a very surprisingly complicated document. From there, we actually pared it down to a nursing responsibilities checklist of sorts, which is now available on all 17 of our patient care units, so that there are unit folders. If an order gets written, a nurse can go to said folder and look at, okay, what do I need to do? And so that's the way that we've tried to ensure consistency from unit to unit, again, just knowing that there is quite a big spread in terms of geography of the number of units that we have and number of teams that we have. So just a sample for you of what our actual responsibilities sheet ended up looking like. So the first point is if there's a diet change when the comfort feeding only policy is implemented, then to enter it in the diet informed food services. If there's no diet change, then just to update the care plan and Cardex and things like that. And the reason we make those distinctions is sometimes, say if someone is going from MPO to comfort feeding only, the physician might specify a specific diet, or sometimes it's a time when diet liberalization can be discussed. So sometimes diet changes happen related to things like removal of, say, no added salt restrictions or diabetic diets and things like that, depending on the conversations with the families. We also have instructions to post some posters, and I'll show you some samples of those in a moment, and to discuss with the team at interprofessional rounds. The family caregiver education piece is also part of our responsibilities checklist, and just to continue to monitor and to notify either the physician or the speech pathologist if there is need for further education, consultation, that kind of thing. So another piece that I want to notify you to, point number 7, if someone stops eating entirely. So for some families, having the tray there can be comforting in the sense that, you know, they know that it's an option, we're not removing it, it's always going to be there. But for some families, sometimes the feedback that we get is that the tray being there is an extra source of pressure. So sometimes there's that sense of, oh, if it's there, then I'm going to feel the need to use the whole tray. So what some of our units have done, and this started on our palliative care units and then subsequently spread to some of our other units, is A, we talk about the option of stopping trays but using foods on the unit. There's always things like liquids and applesauces and puddings and things like that available. But some of our units also have bins in the shared family fridges. So we can tell them, you know, we will label a bin with your family member's name, and then that way we can store some things in there. If it's 2 a.m. and they're hungry, we can grab something from their bin, and then we know there's always food for them, but it negates the need to have an actual tray. So that's an intervention that's actually been quite useful in some of our units as well. Okay, so I'm going to skip to, again, a little bit more detail in terms of what to actually do with these residents, so some feeding strategies. So this is a long list. Some of the pieces that I want to highlight are monitoring for alertness, certainly, maximizing positioning to ensure that, you know, we minimize, not eliminate, but minimize the risk of aspiration, and I'll speak a little bit more to positioning. Offering foods and fluids as someone is able to, and considering as well textures that are going to be easier for them. Watching for the actual swallow before giving more. And so when I do education with our nursing staff, I often say to watch at the Adam's apple or at the throat for a nice up and down movement, because that's how you know someone has actually swallowed and not just kind of dumped the food from their mouth into their throat. monitoring for signs of aspiration, and then doing oral care if needed. Another piece to consider that isn't on this list, but is something that we've had in conversations recently, is also maximizing access to sensory input. So if someone needs, say, glasses or hearing aids to be able to engage in their environment, making sure to use those kinds of tools so that they can participate as best as they can in feeding. So this is a sample of the Bedside guide that I mentioned earlier that is available, again, on all of our patient care units in the same unit folder as the nursing responsibilities checklist. So it has standard generalized feeding strategies and space for someone to write in a resident-specific food and fluid texture. There's also a checkbox for offering small sips of water when requested. One piece we didn't mention is that our comfort feeding only policy does have a specific piece around free water, because that can be a point of, I guess, concern for some families as well. So we do also discuss free water sometimes, depending on the needs of the family and on the nature of the resident. So this is our feeding strategies. You'll notice there as well that the positioning piece is in there. And so in terms of quote-unquote gold standard of positioning, really what we're meaning is as upright as possible with a chin-down position, and just trying to eliminate the head extended chin up position, so in case someone has, say, poor alertness or poor oral control, to prevent any food from passively spilling into the throat or into the pharynx. And so minding with that as well your own position in relation to the person being fed. So if you stand and someone is in a chair and are feeding them from above, they are more likely to look up at the food that's coming towards them and look up at you and to extend their chin upwards. So I usually tell people if someone's in bed, you raise the bed up, or you sit in a chair. If someone's in a wheelchair, you sit and really try to be face-to-face with them. And so what I mean by that is to move from something like this, which is going to be my no-no, and move more towards something like this. So the position you'll notice on the right is much better in terms of facilitating feeding, but also think about what the nonverbals of this communicate. So in terms of respect and dignity and things like that, really being eye to eye and on the same level with someone does have communicative intent as well. So none of this, preferably this. When to hold feeding is also something that we do education around. So oftentimes we'll talk to families about stopping feeding in the moment if there's coughing, throat clearing, shortness of breath, wet gurgly voice, different things like that. So there's a quick reference sheet there for you. But it's also equally important, as I mentioned, to talk to families about what can you do when you can't feed? What are some alternative ways to show that you do care? And so some of the ideas that are here are things like reminiscing around photographs, still having a conversation with the resident, playing favorite music, or reading passages from favorite books. Oral care is also a different thing to try, but really here it's just a matter of being creative and thinking about what is meaningful to that particular resident. And this is just a short list of ideas, but I'm sure that there are lots that you might come up with on your own for specific people. On the note of oral care, I do want to stress this because, A, it's a really important way from a risk perspective of reducing the risk of aspiration pneumonia because of the oral biofilm and aspiration of that. But moreover, if you think about feeding as an effort to promote comfort at end of life, and if you think about that bacteria caking onto the tongue as well, it does change the taste experience that someone would have rather than having a clean mouth. So oral care can be great for that purpose, for taste, as well as for keeping the mouth moist and comfortable, reducing dry mouth, and as part of someone's everyday routine. So similarly to how we get up, get dressed, brush our teeth in the morning, being able to promote that dignity to our residents as well. And so if you do need more information about oral hygiene products, saliva substitutes, certainly feel free to discuss with your interprofessional team members around what's available in your facilities. Another piece around oral care that I'll quickly mention is sometimes I suggest this as a good way of assessing in the moment if someone is ready to feed. So sometimes if you start off with oral care, then you've done oral care and probably improved the taste experience for someone. But also you can see, are they moving their lips? Are they moving their tongue? Are they going to be able to participate in feeding at that moment? So that's another trick and tip that I'd suggest. And this is just a sample of another of the bedside guides that we have in our unit folder. So this one is specific to oral care. So we suggest, in the context of dysphagia, particularly using, say, the green swabs or toothbrush, but just dipping it into your oral care product rather than trying to do toothpaste or gargling of mouthwash. You might want to just be careful about mouthwashes I use because some of them can be drying. Here we have a non-alcohol-based one that we sometimes use, so just be cognizant of the different oral care products that you have. And as Suman mentioned too, there is an oral health best practice guideline already by the RNAO, so I'm sure there's lots of great information and resources in there. Okay, so that brings us towards the end of our content. I just want to recap a little bit into what the benefit is to using a comfort feeding only approach. So for those of you who may need to transfer people out for the purposes of artificial hydration, it negates that need. It does also reduce the need for use of artificial hydration in the end-of-life context in places where you are able to do, say, hypodermic lysis or IV on site. It reframes the conversation so that people can focus on comfort and focus on what can we do rather than focusing on starving to death, dying of thirst. And it does allow just that shared discussion and shared decision-making around end-of-life care. So there's also some benefit in terms of being able to empower direct caregivers, both staff and families, in terms of how to feed, when not to feed, and how to do that online assessment. So I think that is the end of our formal content. Thank you very much for having us, and we'd love to take any questions or comments at this point.
Hello, everybody. This is Suman again at RNAO. If you have a question you can ask, please press *7 to unmute your line and ask a question. In the meantime, Dr. Williams, I'm going to ask a question that was posted online. Are the medical colleges aware of these changes and the prescribing of comfort feeding only, or should this be individually discussed in the homes and the medical team?
We haven't involved any of the regulated health profession colleges, we do actually write it as a physician order at the moment, but I don't think that that's actually a requirement. Whoever orders diets can order that, just depending on how you do it at your home. We write it as an order because we want people to understand we're being quite specific. No artificial hydration, and we know it's not going to be enough, but we're providing comfort.
Anyone else has a question?
It looks like there's a question on printouts. I think, Suman, you're going to make them available?
Yes, so for all the participants, you will receive the presentation, the handouts, and the references within 24 hours of this session today.
So that would include also that brochure for families?
Yes, we will.
The nursing list and those little posters, and also a copy of the policy as it was written in policy language.
Yes.
For Sunnybrook.
Yeah. So everything will be sent out to the participants. There's another question. We have a question regarding diet as tolerated versus comfort feeding only.
That's a good one, because diet is tolerated doesn't actually tell you anything. A diet is tolerated could be accompanied by hypodermoclysis. It doesn't actually give you that the approaches we're providing comfort, and we're no longer counting that we have enough cc's of fluid in a day. So we find this more specific approach much better than diet is tolerated. And also, diet is tolerated can lead you somewhere where you don't want to go, where people think, oh, I can eat anything. And they bring in the steak dinner for a person who's got dysphagia, and they choke to death in front of their eyes. So we're not actually suggesting all diets be whatever, because then you can have more trouble with the feeding. So when we liberalize the diet, we might liberalize it forget about the salt and the diabetes, but we don't usually liberalize texture. Or if someone's allergic to peanuts, we don't, bring them peanuts. Or they have a religious restriction on certain foods. That doesn't mean to bring the tray with pork, or whatever. So we don't actually just say no holds barred on the diet.
Can I just add a piece to that? It's Jennifer, so I'll just add my own 2 cents just to add to that. So the way that I explain this to staff sometimes is that we distinguish between comfort feeding only and the diet because they are quite separate. So the diet texture really speaks to what someone is eating, or the diet speaks to what someone is eating. Comfort feeding only speaks to the fact that we are not worried about the amount they are eating. So looking at it as comfort feeding only as the approach to feeding, not the same as the decision around what to feed someone. And so those are kind of individual discussions in terms of risks and benefits when people are looking to liberalize things. And again, we don't necessarily do that willy-nilly, but yeah, looking at what someone is eating and how they're eating is 2 separate kinds of conversations.
Okay, thank you. We have quite a few questions online, so I'm going to read them one at a time. Is it required that the patient has expressed in writing in advance prior to onset of dementia that they want comfort feeding only?
No, not at all. So you're asking in the moment with the current circumstances to the SDM, or usually, of what to do. And they can reflect on previously expressed wishes, but we're moving away from that sort of advanced consent when it's really the circumstances at the time that have to be considered.
Thank you. The next question is, can you provide an example of a saliva substitute other than Biotin?
Well, we've got whatever brands, Sunnybrook supplies, which is a moisture spray and Oral Balance gel. They're just the brands that we happen to have.
Next question, does this help address the issue of fluid hydration programs in long-term care homes, the challenge with meeting adequate hydration levels in residents?
That's a good thing, because you don't want compliance coming in and jumping all over you for not providing enough. You're starting with the knowledge and agreement that you cannot provide enough fluid to sustain life because the person is at end of life. And so that explanation, that formally says, and the family understands that. So then, although you may be providing it, it's on the tray, it's there, but the person is unable to take it. Does that help?
I hope so. If not, they can ask, they can type the question or ask by pressing *7. I do have more questions, Evelyn. Do families speak with dietitians regarding the nutritional needs of residents receiving comfort feeding only?
That's a good one, because we don't automatically call the dietitian in. They often will discuss their preferences, that, it's the end of life and they'd rather just have ice cream 3 times a day, which is fine. We really avoid the dietitian telling them they're not getting enough nutrients, because that is no longer the issue. So we don't want to bring in someone who explains to them how badly the resident is doing when we've just agreed that they're at the stage of their dementia where they're not going to be with us much longer, and it doesn't matter.
And I'll just add to that, because sometimes when I'm doing a swallowing assessment, I'll get questions of, you know, what about Ensure Boost and things like that. And so the way that I typically respond to those, is Jennifer, by the way, in case anyone is curious. The way I tend to respond to that is to ask the question, well, what is your goal with giving that? Are we looking at the nutrition, or are you asking because they happen to like the flavor? And just to bring it back to what are the goals of trying to provide comfort and provide items for quality of life rather than on prolonging life.
Thank you. Another question that's been put here is if they will be able to share these resources with their staff in the long-term care home. So this is Suman. Yes, we will provide you with the resources that have been shared by Sunnybrook Hospital. We will also be posting it on the long-term care toolkit end-of-life topic. You can use these resources as long as you refer to them saying that they were created by Sunnybrook Health Science Center. There's another question. If the resident is not eating enough, what about the nutritional supplements? Say if they were on ProSource or RS 2.0 before, then should we still continue it or discontinue it?
Again, that speaks to what your goals are. So if someone was able to and wished to take those supplements, I think they would still be supplied in that they're more nutrient dense. But we're actually not trying to give them all of their nutritional needs. We know that the end is coming.
Okay, thank you. And there's a comment, thank you for the presentation, and they would like to share these resources within their home. And a question as well, is there benefit at all with the subcutaneous hydration?
We use it. We usually use it if we're not sure if someone's going to get better. So they have been doing poorly but having enough fluid, they're ill with a respiratory infection, they're not getting enough at the time, so then we tide them over. The second is that we have families, they're not ready to acknowledge that someone's at end of life, so we say, well, look, we'll do this for a while, but then we need to revisit it if swallowing is not picking up, and we need to revisit our goals. So it can temporize both ways until they get better or until we are agreed with the family that there is no getting better.
Okay, thanks, Evelyn. There's another question. What if a home already loosely follows comfort feeding only at end of life without a defined policy? Do you think that it is appropriate, or should we be moving to defining the policy so that we have a defined guideline for staff and families?
It's probably partly the culture of the home. We found it helpful, the education part, for staff who were hesitant to feed someone who sometimes chokes and coughs and has a hard time. We found the education about proper positioning helpful, and we found the discussion with the goals of care helpful with families. But that doesn't mean you have to put it in a policy, but all of those aspects were helpful.
And it's Jennifer again. I'll just add that from a quality improvement lens, what I'd suggest is really just, again, looking at the culture of your facility, looking at the needs of your stakeholders. For us, this was particularly helpful and kind of needed because of the number of people that are involved. So again, we have a huge number of beds here, about over 500, 17 units, which means 17 distinct patient care teams with all different dynamics and things like that. So from a consistency and standards of care perspective, for us it did help to have a policy because we didn't want, different standards of care on, say, Unit A versus Unit B and things like that. So it does depend on your setting a little bit.
Thanks. There's another question. It's a clarifying question. Do you mean the standardize the term comfort feeding only, or comfort feeding only as its own separate entity? For example, regular texture implies no mechanical alteration.
Sorry.
The comfort feeding only, it's written like that as an order. It doesn't actually refer to the texture or the fluid consistency, except that it allows free water with whatever texture and fluid you have.
Hi there. Sorry, can you hear me?
Yes.
I was the one that asked that question. I just wanted to clarify. So do you mean to have somebody go into the EMAR and put in the order as in comfort measures only in that exact wording, implying that this is meant to follow the policy? Should it be implemented in the home? Because I'm just worried that the wording might get misinterpreted and this might be worded as something else, but still implying that they would like comfort measures only. Like, I'm just wondering if you're trying to standardize that as a term.
That's a good question, and it really, we actually standardized the term to mean some very precise things, and we don't use actually comfort measures. The term is
comfort feeding only. Sorry.
Comfort feeding only.
Yes.
It means precisely what the policy says. We find comfort measures as an order or an approach means nothing.
Yeah, no, I just meant
so we've actually, you're right, we were trying to be much more specific about this particular issue of maintaining or not maintaining hydration at end of life.
And also just a quick follow-up question. You had mentioned that you don't regularly involve registered dietitians in this process, whether, you don't want them to mislead the family and kind of tell them how sick they are or whatnot. But going forward, is there going to be more training and education for dietitians? Because this is kind of a food-related issue, shouldn't, I am a dietitian myself, so when I have a resident that is been deemed comfort measures or at end of life or a PPS of about less than 20, I do tend to meet with the family and I kind of go over what their wishes are and essentially do exactly what you said, but there's actually no or very little education for me to go by. It's just kind of going by common sense.
Thank you. We didn't mean to slight dietitians, and Helen Young was involved with us. We just didn't, we wanted, if there's an interaction, that it be on the basis that we're just trying to help provide whatever the resident would like,
yeah, I totally
rather than trying to force them to have, 100% of their nutrients.
Yeah. I just mean that, and I completely agree with everything you're saying. I'm just hoping that maybe going forward with all of your wonderful research, I would love to either help or have something concrete for me to go on as when I do talk to families.
Well, that's a good point, and I think probably there would be absolutely room for dietitians in general to develop along these lines. Well, what is the approach when you're at this stage, and how's it different?
Okay. Thank you so much.
Evelyn and Jennifer, keeping in mind that we're over our time now, I'm just going to ask one last question. Which team member would be the one to acknowledge start of the end-of-life care, the RN, the MD, or the administrator?
We tend to have the physician and the team having that conversation with the family about, okay, this is where we're at. We're at end of life. Because you do need the family to have that understanding, but because we all work together on it, we can all talk about it. But I think if the family doesn't believe that they have a terminal, the person has a terminal illness, you're not going to go there yet.
Okay, thank you, everyone. If no one has any further question, I'd like to thank Dr. Evelyn Williams and Jennifer for doing this presentation for us. It is a huge topic in long-term care homes. And we will, within 24 hours, we will send the presentation and the associated resources and the references to everyone who attended today. When the recording is available, it will be posted on the Long-Term Care Toolkit in the end-of-life topic. Thank you, everyone. Have a good afternoon.
Thank you.
Thank you.